So one of the questions I get asked a lot is, so why is blood management important in cardiac surgery? And blood management is important because it's central to every single thing you do. You don't do a single procedure in cardiac surgery without making some blood management decisions. And the blood management decisions you make affect the patient's outcome. So by improving your blood management, you should improve outcomes. And there's some evidence to support that. So for example, there's this very kind of clear relationship between the number of units of blood you receive and mortality, although we'll consider why some of the reasons why that may be confounded in a second. But there's also strong associations between coagulopathic hemorrhage, restenotomy for bleeding, and mortality as well. And then moving aside from the immediate effects on outcome for our patients, there's also the opportunity costs of transfusion, and you have to consider what impact we have using blood components has on other aspects of healthcare. So for example, in the UK, we use about 15% of all blood components in cardiac surgery alone. In the US, it's more like 25%. And we have Axel Hoffman here today from the Society for the Advancement of Blood Management and the Medical Society for Blood Management, who will talk to us today about the economic issues that surround blood conservation to try and put it in a slightly broader context. So as I said, we use an awful lot of the blood components in the UK and elsewhere. There's also a very high prevalence of coagulopathic hemorrhage in cardiac surgery. I'm going to focus today on cardiac surgery because we want to talk about evidence, and there is no evidence for blood management in thoracic surgery. So that's a deliberate, it's not that I'm ignoring thoracic surgery, there's just no evidence in thoracic surgery. So we're going to talk about cardiac surgery. We know that we have a high red cell utilization of non-red cell utilization, and we also have a very high rate of coagulopathic hemorrhage, which depending on how you define it, can occur in almost 1 in 6 patients. The main thing about cardiac surgery is that we know exactly when it's going to happen. It happens in an incredibly monitored environment, and therefore we should be able to use interventions that improve how we make blood management decisions. We should be able to analyze it and refine it, and we should be able to improve outcomes. This is something I use for the Birmingham Review course, which is a postgraduate course in cardiac surgery, but it just shows you that there are many different modalities that you can use, and we're going to consider most of them today. I'll not go into this slide. We do have some published evidence-based guidelines for blood management, but these guidelines simply serve to tell us how little evidence there really is. So this is the 2011 revision of the initial guideline, and of the 57 recommendations, only 7 were actually level 1 evidence, of which 2 were wrong, because 2 of them were recommending that we use a protein. And we now know that that's no longer the case. So actually the evidence base for our blood management is very poor, even though it's central to what we do, and it's a very important determinant of outcome. What is emerging is that there are some key kind of concepts that we should use in blood management, which we don't use very much, are the importance of pre-assessment, how much decision-making we go into optimizing patients preoperatively. It's something that we don't do. Something we don't do simply because of the pressure of getting the patients through our unit. I don't think it's because we don't want to do it, but we don't do it. Point-of-care testing is an emerging important theme, particularly in how we define coagulopathy and how we manage coagulopathy. And then there's this new kind of paradigm called patient blood management, and sometimes I like it and sometimes I don't. And I'm not sure about the evidence base for patient blood management, how robust it is, but it's this new concept that's been called patient blood management, which has really taken hold, and it's the language that we're using nowadays, and it's actually enshrined in these guidelines. So our first international guest speaker will be talking about perioperative anemia, Marco Ranucci, and actually anemia is the key because it's what we're avoiding. Blood management is all about avoiding or reversing anemia, because that's where we think the pathophysiology comes from. The risks you have having low anemia during cardiopulmonary bypass and afterwards. So Marco was one of the very first academics to highlight an association between low hemoglobins during cardiopulmonary bypass and adverse outcome. So we're very grateful to him for coming here today to talk to us about this. Next, we'll be considering this apparent paradox that a low anemia seems to be bad for you, reversing anemia with red cell transfusion seems to be worse for you. But it's not simply a paradox in that there's apparent conflict, but actually There's great confusion among the evidence. The observational studies show that yes, if you reverse a low hemoglobin with a red cell transfusion, it's worse for you. But the randomized trials do not. And we also consider the reasons and we'll review the evidence and see if we can make some sense of that. Will Leicester is the first of our haematologists to speak today. And if I could just say, I'm particularly pleased with the large number of haematologists that we have with us today, because we're not really going to improve blood management unless we have a much wider debate. And Will has come up from Birmingham, and he's an expert in anti-platelet agents and platelet biology, and he's going to talk to us about current anti-platelet agents, what the evidence is for their use, their benefits, and the risks of stopping them before surgery. Then we've got Andrew Klein, who's going to talk to us about the evidence surrounding autotransfusion, whether that's preoperative autologous donation, acute normovolemic hemodilution, or cell salvage, and so on. And there's an awful lot of evidence for that. So the recent Cochrane review had something like 150 randomized trials. So there's a lot of evidence there. It's probably where we have our best evidence base. Then we've got Andrea Kelleher, who's an intensivist from the Brompton, who's going to talk to us about tranexamic acid. Tranexamic acid is very in vogue at the minute because of the CRASH-2 study, which is a study in trauma patients where it had a mortality benefit. Whether it is the same benefit in cardiac surgery isn't quite clear. There's also lots of other issues around tranexamic acid. Finally, we're going to talk about aprotenin. Aprotenin we thought was dead in the water, but recently the German equivalent to the MHRA and the Canadian equivalent to the MHRA have reissued the license for the use of aprotenin in cardiac surgery. So the question is wide open. And there's so much confusion. It's amazing how you can do good research and still have confusion. So you've got this original Mangano paper, which showed there's massive increased risk of renal failure attributable to aprotenin, and then you do a high-quality randomized controlled trial of aprotenin versus tranexamic acid. You see absolutely no causal effect whatsoever, so there's a lot of confusion there. And we're very fortunate to have Professor David Cheng from Ontario today. He's one of the co-authors of the BART study, and we're going to ask him to talk and tell us about what's going on behind the BART study and more recent developments. So we're very grateful for him for coming over today. I show this slide because it always makes me laugh, because everyone in the room kind of goes, oh God, we've been looking at that slide since we were like 19. We didn't understand it then, we don't understand it now. And we've got Helen New, who is a haematologist from Imperial College, who's going to come and talk to us about that today, and I thank her for coming. And hopefully what we just need to know is we have to know, what is coagulopathy? Do you know what coagulopathy is? Because I have no idea what coagulopathy is. You know, the universal definition of coagulopathy is a PT ratio greater than 1.4, I think. And yet our evidence-based guidelines show that using that threshold as a means to diagnose coagulopathy in cardiac surgery has absolutely no diagnostic validity whatsoever. So what is coagulopathy? How do we diagnose it and treat it? Then we're going to look at non-red cell components. There's some evidence that they're bad for you. There's some evidence that they're not bad for you. Will Leicester's going to tell us about that. Is it context-specific? For example, there are units in this country, it takes them an hour to get a unit of platelets. When you have a unit of platelets, it probably doesn't do you any good. Where I work, it takes me 7 minutes to get a unit of platelets. We don't use any other blood conservation modalities, really, because we can get platelets just like that. Maybe they're not so bad for you if you use them whenever you need them. Finally, we've got Paula Maggs Bolton, I'm always getting her name wrong, who is the director of the Serious Hazards of Transfusion program here in NHSPT in the UK. Hemovigilance is something that we don't know very much about in cardiac surgery, but this is going to become increasingly important. As blood becomes scarcer and becomes more expensive, and the risks of transfusion become more widely publicized, you'll find that you're undergoing an awful lot more scrutiny about when you give blood components or use blood conservation interventions. And we're going to find eventually that every single transfusion we give, we're going to have to make a hemovigilance report on that. So we're very grateful for her today to come and talk to us about that. We've got Mark Ranucci, is going to talk to us again about point of care testing and how we diagnose and treat and best treat a coagulopathy in cardiac surgery, because we think conventional tests aren't so good. But we've got this new range of techniques that may be good, but they may not be, and we have to evaluate that. Helen New has led the way in a new field in blood management, which is in paediatric cardiac surgery. So you know, until very recently, we were just happy that children survived paediatric cardiac surgery. Now we're at a stage where we have to refine paediatric cardiac surgery and paediatric anesthesia. And one of the things we realize is that we don't really know if they bleed whether they're coagulopathic, how much blood they use. And actually, for the first time, we're beginning to get an idea of that and the scale of the problem, and realizing that it's as big a problem in pediatric cardiac surgery as in adult cardiac surgery. So Helen Yu is going to talk to us about that. And finally, we're going to talk about some Baylor adjuncts. We're going to Ravi Gill, who's published the pivotal trial in recombinant activated factor 7, is going to talk to us about that. And we also have a young researcher from NHSBT who's going to talk to us about new and emerging blood components, about whether or not we're going to be using cryoprecipitate in 10 years, whether we're going to be using FFP in 10 years. And these are some new products, and they have been evaluated in some small studies. And Nicola Curry is going to tell us about that. She's a hematologist. She's also working with the big trauma program that NHSBT and the NIHR have funded at the Royal London. Finally, the question we have to ask ourselves is what we're doing is improving outcome. Because I tell you what, all the politicians have already decided. Blood management is already enshrined in health policy. What's the evidence that what we do actually improves outcome for patients? And that's the big question. That's the thing that I want to be the central theme of today's sessions. So we'll start off, before I go on to my next lecture, I'll ask you for any questions just at the moment.